Good evening, everyone. I, Dr. Aarti Heda, along with my co-moderator, Dr. Neeta Dodwad, welcome you all to this wonderful evening, and I should say wonderful morning. Today, we are here to install the 24th international chapter of ISMSICS, that is Latin America chapter. So we'll begin with introducing the office bearers of ISMSICS. So we have with us Dr. Amulya Sahu sir, who is the founder chairman of ISMSICS. He was the past president of Bombay Ophthalmological Society and is a nationally and internationally acclaimed cataract surgeon who has introduced the 2 MSICS technique. Dr. Sahu is the founder chairman of Sahu Eye Group of Hospitals in Mumbai. Over to you, Sahu sir, for your word of wisdom.
Thank you, Aarti. I welcome all the participants from all over the globe, especially our valued friends from the Latin America. All of you are welcome to ISMSICS family. I was observing from the background a talent called Gonzalo. His dynamism, commitment to the cause of MSICS, keeping self above the cause, and quality of true leader. I thank you, Gonzalo, for bringing so many prominent ophthalmologists from Latin America on our platform. In recognition of your contribution of managing committee of ISMSIS has decided to give free membership to all the managing committee of your chapter.
Thank you.
And give free registration and local hospitality to one member from each country of Latin America for our conference in Delhi in 2025. We have also decided to honor you, Dr. Gonzalez, in our 6th World Conference in Delhi and announce him as an international coordinator of MSICS. And we want Latin America to be a vibrant chapter promoting MSICS. We'll all cooperate to promote MSICS in Latin America and learn from them also. Thank you. Welcome to this chapter. Thank you so much.
Thank you so much, sir. So next we have with us Dr. Jagannath Buramani sir, who is Executive Chairman of ISMSICS. He has pioneered and popularized small incision cataract surgery under topical anesthesia. Recipient of multiple awards, Dr. Buramani is well known for his X-chopper for the closed chamber manual phacofragmentation and customized incision cataract surgery. Over to you, Buramani sir.
Sir, you're muted.
Yeah, can you hear me now?
Yes, sir.
Yes.
Good evening, all of you, and good morning, all of you from Latin America. I welcome all the Latin American office bearers with the launching of this new chapter of Latin America. Dr. Aarti, can I introduce the ISMSICS to the audience?
Sure, sir.
No? Yeah. So I'll be sharing a video so that everyone will come to know about the journey of ISMSICS. Can you see my slide?
No, sir, we are not able to see your screen. The screen is visible now.
Yeah, but I can't see.
I can see the screen, but not the video.
Sir, I can share it from my end, sir. No problem.
Yeah, you can share it. No problem.
Yeah. So can you please stop the screen share?
Yeah.
tunnel incision is a secure incision. There are newer advances in MSICS, like 2 mm SICS surgery, smart incision surgery, and customized incision cataract surgery. The International Society of Manual Small Incision Cataract Surgeons was launched in 2005 by Dr. Amulya Sahu, the founder chairman, and by Dr. Jagannath Boramani, the present executive chairman. Immediately after the formation, ISMSICS started organizing many international events. ISMSICS was invited to conduct a wet lab in APACRS in 2015. In 2018, in WOC, ISMSICS conducted a session and a wet lab. The Master's Guideline ebook was launched during this conference. In 2022, the ESO invited ISMSICS to conduct a 2-day workshop in Dubai. In the same year, the organization conducted a session in Ransko. In 2023, the annual conference of Emirates Society of Ophthalmology, ESO 2023, ISMSICS was given a session, a workshop, and a wet lab. In the same year, ISMSICS conducted a session and performed live surgery in Moscow. In ESO 2024 again, ISMSICS conducted a session, a workshop, and a wet lab. APAO 2024 offered 2 wet labs to ISMSICS. In India, ISMSICS has regularly been invited to various CPD programs, state conferences, and to participate in AIOC, the largest conference in India. ISMSICS started holding world conferences every 2 years, from 2015 onwards. CCC stands for Comprehensive Cataract Conference. Our past partners for these conferences were Aravind Eye Care System, Disha Eye Institutes, PGI Chandigarh, and LV Prasad Eye Institute. And in 2024, ISMSICS conducted the first zonal conference in Geo World Convention Center, Mumbai. In 2017, ISMSICS became a partner of Help Me See for training on simulator. ISMSICS has chapters in almost all states of India and in 22 countries across the globe. These are few images of online, as well as physical launching of chapters in various countries. ISMSICS has conducted more than 80 online webinars. The organization has a women's wing also.
Editor-in-Chief of Global Journal of Cataract Surgery and Research in Ophthalmology. He has taken many seminars and webinars to educate the postgraduates for the glaucoma as well as the cataract surgery. With this introduction, I invite Dr. Barun Nayak, sir, to say a few words for this prestigious occasion. Barun,
I welcome you all. Yeah, can you hear me?
Yes, sir.
Yeah. Good evening and good morning, everyone, with a different part of the world. And I welcome you all to this important from Latin. So it's really a great moment moment for us that our wings are spreading all over the world rapidly. Thank you very much, Dr. Neeta. Go ahead.
Thank you, sir. Thank you for those wise words. So we have our next office bearer, Dr. Satanshu Mathur. He is the Chief National Coordinator. He is an ophthalmologist and he's based at, he's the founder of High Tech Eye Institute and Laser Center in Kashipur, Uttarakhand. He's well known for his surgical training and wet lab training all over India throughout the AIOS conferences. Dr. Satanshu sir is there, Aarti.
No, he'll be joining us shortly.
He'll be joining us shortly. Thank you. So next, we have with us Dr. Deepak Mishra as the Secretary of ISMSICS. He's Associate Professor at RIO Varanasi. He's Member Academic and Research Committee AIOS. He's Zonal Member of FBS AIOS and Chairman Postgraduate Activity of ACOIN. So with this short introduction, I welcome Dr. Deepak Mishra sir to say a few words. He will be joining us shortly. Now we have a very young, dynamic and active National Coordinator of ISMSICS, my co-moderator, Dr. Aarti Heda. She is a consultant and anterior segment surgeon who is based in Pune, Maharashtra. She is also Associate Editor of Global Journal of Cataract Surgery and Research in Ophthalmology. Over to you, Dr. Aarti.
So thank you so much, Dr. Neeta. So before we move on to the installation, we would like to invite Dr. Gonzalo to say a few words. So let me just thank Dr. Gonzalo for his efforts to putting things together and coming up with this excellent Latin America chapter of ISMSICS. Over to you, Dr. Gonzalo.
Hi, thank you. Can I show my slides or?
Sure, please.
Okay. Okay, it's okay, right?
Yes, we are able to see your screen.
Yeah. Well, first of all, it's an honor for us to be part of this. It's really a pleasure. I want to all of you introduce the members of the Latin American chapter of the ISMSICS. So our chairman is Dr. Neil Ramirez. He's from Venezuela. Our vice chairman is Dr. Rousseau. He's from Bolivia. He's one of our speakers today. Our president is Dr. Noé Rivero from Argentina. Our vice president is Dr. Juan Carlos Ginés from Paraguay. Our secretary is Dr. Jorge Jaramillo from Colombia, and me as a coordinator. We have also scientific committee members, Dr. Ariel Garcia from Argentina, Dr. José Morote from Bolivia, Dr. Juan Camilo Cadavid from Colombia, Dr. Germán Bianchi from Argentina, and we have also an executive committee members, Dr. Amilcar Fochesato, Dr. Carlos Gomez, he's one of our speakers also today from Dominican Republic, and Dr. Katiana Garcia from Panama. So as you can see, we are trying to involve all the country as we can of Latin America. We have been already, we made already the launch of the M6 LATAM chapter in the past Congress of Fago Extrema in Buenos Aires. This Congress is one of the biggest here in LATAM, and we could do this launch of the M6 LATAM chapter in this Congress. So this was in August, just like 2 weeks ago, 2 or 3 weeks ago. And also we already do some wet labs in the Congress, and these wet labs we can share this technique with other colleagues with other ophthalmologists of LATAM. So this is just to show you that we have been do some activities, some wet labs, some presentations, and this is our idea. So our main goal here in this LATAM chapter is that we can show and to teach this technique to other ophthalmologists of LATAM. Thank you.
Thank you so much, Dr. Gonzalo, for your enthusiasm. We are very happy to have you with us as a family. So can you please stop your screen share?
Yeah.
Gonzalo? Yeah.
Here. It's okay.
So let's begin the installation of the chapter. So we have Dr. Gonzalo has already introduced the members from the Latin America chapter, but I will just install them formally. So
Yeah,
we have
perfect.
Dr. Neil Diaz as chairman. He is anterior segment surgeon in the city of Caracas in Venezuela. So I invite Dr. Sahu sir to please install Dr. Diaz as the chairman of Latin America chapter of ISMSICS. So you're muted, Sahu sir.
Okay, welcome to you, sir. Message.
So we have with us Dr. Juan Russo as vice chairman. He is anterior segment surgeon practicing in Institute of National de Ophthalmologia in the city of La Paz in Bolivia. So I invite Boramani sir to install Dr. Juan as the vice chairman of Latin America chapter of ISMSICS.
Yes. Welcome, Dr.
Thank you
Joan. I
very much.
declare that Dr. Joan Alfonso Russo is installed as the Vice Chairman of LATAM chapter of ISMSICS.
Thank you very much.
Next is a president of ISMSICS chapter, Dr. Noe Riverio. He is an anterior and posterior segment surgeon. He is working at Instituto Microsurgery Ocular SRL. He is from Rosario, Argentina. I request our president, Dr. Barun Nayak, to install Dr. Noe as a president. Dr. Boramani, you can. Yes.
I
You're
invite the president to join this.
Thank you, both the presidents. It's our honor to have both of you here. Our next vice president is Dr. Gian Carlos. He's a cornea, cataract, and refractive surgeon. He's working at National University of Asunción from Paraguay. I request Dr. Ashok Nanda, sir, please install Dr. Gian as vice president.
Thank you, Dr. Joan. I welcome you to this community of ISMSICS.
Thank you, sir.
Next, we have Dr. George Jaramillo as secretary of the Latin America chapter of ISMSICS. He is the trained anterior segment surgeon from Medellin in Colombia. So I invite Dr. M.S. Ravindra sir to install Dr. George as secretary.
To install Dr. George as Secretary of ISMSICS, and all the best, and we look forward to great work from Dr. George.
Thank you, sir.
So next, I am very happy to introduce Dr. Gonzalo Zara as the coordinator of the ISMSICS Latin America chapter. He is the cornea, anterior segment, cataract and refractive surgeon who is from Temico, Chile. So I invite Dr. Purvi Bhagat ma'am to install Dr. Gonzalo as the coordinator.
Thank you, Dr. Aarti. Welcome, Dr. Gonzalo, and it's a real pleasure to have you at the core of the chapter and manage all the coordination. And best wishes to the chapter. Thank you.
Thank you.
So next we have 4 scientific members we have Dr. Ariel Gracia, he's from Argentina, Dr. Joyce Carlos Roman from Bolivia, and Dr. Bianchi from Argentina, and Dr. Juan from Colombia. I request Dr. Boramani sir to induct all the scientific.
Yeah, I welcome all the 4 scientific committee members to the ISMSICS family, and we look forward to a lot of events, joint events in future.
Thank you, sir, and congratulations. Next, we have executive committee members, Dr. Emilio Carr, he's from Argentina, and Dr. Carlos Chavez, he's from Dominica Republica. Next, we have Dr. Cantina Gracia, she's from Panama, and Juan Rontono from Argentina. I request Dr. Purvi ma'am to install all the executive members for this prestigious occasion.
We welcome all the members to the ISMSICS family, and we look forward to great collaboration. Thank you and congratulations to all of you.
Thank you, ma'am.
So once again, we congratulate the office bearers of Latin America chapter of ISMSICS, and we are very happy to collaborate with you. And I'm sure the journey is going to be very, very interesting for both of us, and it will be full of learning. So with this, we invite Dr. Purvi Bhagat and Dr. Rajvinder Kaur to take this session forward. Over to you, Dr. Purvi.
Thank you, Dr. Aarti. And once again, congratulations to the Latin America chapter, and best wishes for the tenure and work ahead. So as we move on to the academic part and the scientific content of the program, I would again request Dr. Gonzalo to invite the first speaker from Latin America for his presentation.
Yes. Our first speaker will be Dr. Carlos Gomez. He's an excellent anterior segment surgeon from Dominican Republic. He's one of our BIP members. He's very famous here in this area. So it's an honor for me to present him as our next speaker, Dr. Carlos Gomez from Dominican Republic. Please, Dr. Gomez.
Yes, hello everybody. Hope
Hello.
you can hear me well. Can you
Yes,
hear me?
yes, absolutely. Yeah.
Okay, let me get my presentation on. See if I can do that. At least try. Is it on now?
Not yet.
No, sir.
Is it on
Yes.
now?
Yes, yes.
Yeah.
All right. All right.
Thank you.
So, yeah, my name is Carlos Gomez. For those who didn't hear it before, I guess you all did hear it. I'm very pleased to be here today and being introduced to this chapter of such a thing that I enjoy doing so much for so long time. I've been doing ISMSICS since 1988 when I finished my residency program. And I was really glad to hear that you guys are using the stimulator that Dr. Glenn Strauss and I worked so hard to actually start getting into shape. Well, I want to present to you my technique. I'm the president of the anterior segment department, the director, and the cataract clinic at the Elias Santana Hospital in Santo Domingo. I also have my clinic at the Instituto de Cirugía Oftalmológica. I have no financial disclosures. And I have 2 basic concepts that I have in my mind when I do surgery, especially ISMSICS. One of them is to preserve the tissue and restore the vision. That means you have to do so trying to induce as less damage as possible to the tissue that you're working on. And the other concept that I have in my mind forever is that the day I stop learning, I lose the passion for what I do. So I'm always in constant changing and learning and making sure that I'm doing things right. So my technique has been going through so much evolution during the years that what I'm doing right now is probably not going to be the final process, but it's work. It works for me, and it works for the residents when I teach them to do this at the hospital. In my case, and I know that the technique for other people is different, but in my case, M6 stands for manual small incision cataract surgery. But in my case, I know that the incision is not so small, so I recall it manual sutureless incision cataract surgery because I don't suture the incision, but it's not so small. Why do I do this technique like this? First of all, it's a safe technique that I can perform any kind of cataracts and still get the best results that I can get anywhere that I do it, especially when I don't have all the resources. The phaco is the one thing around the world going around. Everybody's doing phacos. I do a lot of phacos, most of my patients, but when I go on a project, that I go on a campaign, I don't do phacos. I do M6 on basically every patient, and it works. Two pairs that are probably the main two things that I have in my technique that I teach everybody. Number one is a tunnelized and beveled incision. It has to be like that, otherwise the procedure is not going to be as safe as it should be. And the other thing is the lens rotation. I rotate the lens to get it out of the posterior chamber, get it out of the bag, and you will see a video later where I do this just about the same thing every time. But the tunnelized and beveled incision has to be constant on every case. It has to be performed perfectly. So let's talk about the tunnel first. I do the tunnel in 3 steps. The first plane is a perpendicular incision on the sclera that goes straight down into the sclera, and then I sort of conduct my knife in a different position going forward, and that's plane 2, going horizontal incision through the sclera and clear cornea, but I don't go into the anterior chamber yet. If you go into the anterior chamber while you're doing this part of the incision, then your incision is not going to be safe because you're too close to the iris and everything else that's down there. Then the plane 3 is a corneal incision where I go in. It's a bare bevel incision and angle through the cornea and into the anterior chamber. If I follow these steps on just about every case, the incision is going to be self-sealed. It does not need sutures, and it will heal rapidly because part of the cornea, of the incision in the cornea, it heals very fast. So you don't need to suture this cornea, and I will show you later how I do it. So basically, I do an incision, and obviously this is what I teach, but I normally do it a lot smaller than this. But it's a 5 to 6 millimeter incision on the sclera that I can do straight incision or I can do frown incision. But on the inside, the incision has to be a little wider, so it turns like into a funnel type. And I do so I can get the lens into this funnel to get it out, because I can press the sclera down, but I don't want to hurt the cornea inside. So I make the lens go into this funnel, bring it out, and press down on the sclera to get it out. We'll see on a video practically how it's done. This is just a diagram just to teach people and show people the basics of my incision. So when I do the incision, I use a crescent knife, and I use a frown incision on the sclera, and I use it like a fan to create the tunnel, but without going into the anterior chamber. And it's not until I want to go into the anterior chamber that I use a phaco knife or a keratome just to go in and make sure the tunnel is complete when I do this. So let's watch a video, and I hope you all see it. Can you see the video there?
Yes, it's very visible.
Okay, so I'm designing the size of the scleral size of my incision. And what I do is that I tunnel, I go on the sides, and I go into the cornea without going through it into the anterior chamber and try to maintain what I do on the same plane. So there's no steps, it's one plane, and then I go in with phacoton and I stab incision, and you can see the lip of the cornea that's there on top of the knife. Now, the second part of it is the lens rotation. I have 3 little videos that I put together just to show you how I rotate the lens outside the bag and into the anterior chamber. And it's about basically the same thing on every time that I do it. These are 3 different cataract procedures that I did and I recorded, and I put together this video so you can see the way I do it. Here goes the first case. It's a very dense cataract. And what I do is I try to set loose, rotate a little bit, slowly and firm, and I make that the lens comes up on the other side of the place where I'm pushing down and around just to make sure it's in the anterior chamber. And you can see once it's in the anterior chamber, then it's easier to go in and fish it out. So I make sure very clearly, this is another case, and it's a harder lens, and I loose on one side, then try to move it on, try to make sure it's loose, and then I start pushing down and around and make sure that the lens comes out of the bag safely without breaking the capsule. As you can see, it was the same movement, the same motion that I did on the first case. This is a darker lens on a smaller pupil, and I can still do the same thing. And I go around and make sure it's loose, so I move it around a little bit. You can probably see it not so well on the video, but you can still see it rotating, same thing, always doing the same motion, applying the same force slowly, making sure it's rotated and it's on top of the iris. Now I'm going to show you the whole procedure. From first moment is I cut the conjunctiva off, take it off, and I cauterize the vessels. I'm not going to show you the whole thing because it's kind of boring. I sort of cut out the video to make it shorter. And I can go and do the incision one way or the other. This one was a little bit too close to the limbus, which I don't normally do, but it worked. Also, it's very important to have good knives to do these incisions because, as you can see on this video, this knife was not so good. But it still works. It has to be done the same way. Keep the same plane. Always one plane, funnel incision. And I make 2 side ports. So I can work on different things on the 2 side ports. I can do capsulorhexis or capsulotomy. It depends on which I want to do. Most of the time I do capsulorhexis, and I don't use the needle anymore. I use micro utratas to do this, and I make it very wide for a dense cataract. Here you see I'm rotating the nucleus same way as I rotated the other 2, and it's almost the same thing every time. There you go. It's loose. On the anterior chamber, I go in and fish it out with the lens loop. And I hold at 6 o'clock, bring it out, pushing down on the sclera and bringing it out. Then I irrigate and get all those big chunks of cortex out just with irrigation. Put viscoelastic on and then get the lens in. Most of the time I use three-piece lenses. This occasion, for some reason, I didn't have one. But that's basically the technique that I use. But I always try to do the same thing on every case. I use very little instruments, and I can do this anywhere with the use of the microscope. When I go on projects and I go on missions, I make sure that I have my instruments and a scope that I can see what I'm doing. I've worked all around the world. I've done missions in Central Asia and other places in Latin America. And it's always the same thing. And patients are doing very well. So this is the thing that I keep in mind all the time. The day I stop learning, I will lose the passion for what I do. And I never forget this, because every time I'm watching a video, watching somebody do surgery, I'm trying to see what can I learn from what they're doing. Whether it's that I'm learning that they're doing something wrong or that they're doing something right that I can apply to what I do normally. And that's why I keep saying that my technique is in constant change and always evolving. Thank you very much.
Thank you, Dr. Carlos, for that excellent presentation and such beautiful videos and very clean and neat surgeries, absolutely. And yes, whether phaco is a better surgery or MSICS has always been the topic of debate. And in spite of you being a phaco surgeon, you still believe in the science of MSICS is really, really very impressive. So, any questions from anybody, or somebody would like to comment, give their inputs?
Yeah, Dr. Carlos, is excellent surgery, neat and
Yes,
clean
sir.
and confident surgery. Thank you.
Dr.
Thank you,
Carlos,
sir.
do
Yeah.
you do hydrodissection? We have not seen it before the nuclear rotation.
When I do hard lenses, I don't do hydrodissection. I rotate. I remember when I learned to do extracapsular cataracts, my professor, Dr. Juan Valle, taught me how to rotate the lenses. Hydrodissection was not a thing back in the days, so I learned to rotate just about every lens. I do hydrodissection when the lenses are not so hard. And mind you, when I do go on a mission, I find people with cataracts that are not so hard. So I do hydrodissection, make sure the lens is loose. It's a lot easier to rotate when the hydrodissection happens. I don't hydrodissect on hard lenses because normally they are very attached to the posterior capsule. And I've had cases where I try to hydrodissect and the posterior capsule broke. So I try to avoid it. I'm very careful rotating just for that. And as you can see, I rotate very slowly and firmly just to make sure that it's loose from the posterior capsule and release into the anterior chamber.
Okay.
Anybody else would like to ask, Dr. Nanda, sir? Yes.
Yeah, I just have a question. It is fine with hard cataracts grade 3, grade 4 to do that without a hydrodissection. So you can probably have a firm grip and rotate. But what about grade 1 and grade 2 cataract? How do you manage that without hydrodissection?
Well, the white cataracts are Pandora box. Yeah, you never know what's going to be inside there. So most of the time I do blanco punction on white cataracts just to make sure that there's no fluid in the bag. And then do capsulorhexis or capsulotomies, whatever I have to do. But when I do the puncture to subtract the fluid, I realize if the cataract is hard or it's very fluid or it's soft or whatever. Most of the time when you have white cataracts, the nucleus inside is smaller. So it's easier to, just irrigate in there and set loose the nucleus to make sure that the cataract comes out.
He's asking about grade 1, grade 2 cataract.
Soft cataracts.
Soft cataract.
Oh, the soft cataracts, I always hydrodissect, always, because it's easier to see the wave when it comes down through it. And it's easier to get it unattached from the posterior capsule, and it's easier to get out that way. It's hard to rotate a soft cataracts without doing hydrodissection. I don't even try it anymore. I've learned that a long time ago. You hydrodissect every soft cataract. Sometimes when you hydrodissect, and they even come out into the anterior chamber, so you don't have to do much. But you have to hydrodissect the soft cataracts. For me, it's a no negotiated thing that I do, no negotiable.
Okay.
So do you put superior rectus suture?
I never suture the sclera, very rarely, because what I do is that I create a very beveled incision on the cornea inside, and what I do is that I leave an air bubble inside, when the patient gets up, that air bubble will put pressure on the cornea and would seal it. You know, the cornea would seal in a matter of a couple of hours. My experience is that, you know, I don't put a very big air bubble inside the anterior chamber. I fill it out just enough to make sure that the side port incisions are covered and the main incision is covered by the air bubble underneath it. Very rarely I do it as suture. Maybe if the incision is not properly built, or that I know that the patient that is not very cooperative and is going to be moving around, you know, later on. But I do that. I put an air bubble that it will go away within a day or two, and the patient will see fine. My experience on missions is that I see my patients the next day post-op, and most of the air bubbles are more than halfway gone by the next day. So they are very comfortable with that. I explained to them they're going to be seeing this air bubble moving around a little bit, but they still very happy. When you take a patient that's in hand motion, 2400, 2100 with the cataract, and they're seeing 2040 the next day, these patients are so happy, they don't complain about anything. You know, you did a good job. And it gets better. So, you know, the air bubble will not be a problem for the patients. But I rarely ever do a suture.
Thank you, Dr. Carlos. I'm sure there is a lot to discuss and a lot to learn from your surgeries. But considering the time constraints that we have, I would request Dr. Gonzalo to please invite our next speaker for the presentation.
Okay, perfect. Thanks. Our next speaker is from Bolivia. He is our vice chairman of the LATAM chapter. He is Juan Alfonso Rousseau. He is an excellent surgeon, anterior segment surgeon from Bolivia. So, Juan, you can start with your presentation.
Okay, thank you very much. I have ¿se escucha?
Sí, se escucha perfecto.
Okay. I have prepared a video for this occasion.
I would like to thank the ISMSICS board for the valuable opportunity to join this important global institution. I would like to present a video of what we do in Bolivia, a country located in the center of South America, a country of approximately 14 million people, with a cataract surgery rate of 700 per million, where cataracts are operated on with phacoemulsification and also M6. There are surgeons from reference centers who have a CSR of 2,000 per million and others who have 0, with uneven distribution for area as in the rest of the world. I have chosen this case of a 45-year-old woman diagnosed with posterior subcapsular cataract with visual acuity of 2200. She has a history of corneal decompensation due to the disinsertion of aphthic from an iris cloud IOL for 2 months and subsequent penetrating keratoplasty. The transplant is 2 years old and is transparent, with acceptable cell counts of the 1,500 cells per square millimeter. I choose to do M6 to protect the corneal button that's 100% transparent, and because she has 3 previous surgeries: 1 iris cloud IOL implant for myopia, 2 IOL implant for corneal decompensation, and 3 KP for corneal decompensation. In 2 years, she developed a posterior subcapsular cataract. The anesthesia I use is 1 ml of sutenonium lidocaine. My technique is basically 6 mm long scleral tunnel, 2 millimeters from the limbus to be able to implant a rigid IOL of plus 5 diopters with an optic zone of 6 millimeters and aptic of 13 millimeters. Lower paracentesis, upper paracentesis, trypan blue injection. I inject a lot of viscoelastic to protect the endothelium, and I like to work very close to the capsule, away from the endothelium. Capsulorhexis. I do dissection, dislocation of the lens nucleus with a Becher spectral and a viscoelastic cannula. Station on the lens nucleus with a Kansas loop. Extraction of the lens nucleus with a Kansas loop into a stage because the nucleus is soft and fractures. Washing of the epinucleus and remaining cortex to the main incision and through the paracentesis to reach in 12 false mass. IOL implantation. Basically, the lower optic is introduced into the bag as well as part of the optic. The Nasinski hook is rotated 360 degrees. One simple stitch of suture with 10-0 nylon. Washing of the viscoelastic through the main incision through the paracentesis and below the IOL. Closure of the conjunctive with electrocautery. This is a photograph of the patient the day after surgery. Thank you all very much for your attention.
Thank you, Dr. Russo. And that was indeed a very challenging case that you showed. Any questions for Dr. Russo?
Yeah,
Yes, sir.
Dr. Juan, thank you. It's an excellent surgery, and you did the right thing in choosing to do a little posterior incision and going into the not going into the donor cornea rather than keeping your incisions in the host cornea. My observation was that you did the side port, the paracentesis at the lower limbus. As far as the incidence of infection or endophthalmitis goes, inferior limbus should practically be avoided to prevent infections. The lateral paracentesis could be better. What is your reason for doing inferior paracentesis?
Por favor, voy a pedir auxilio a Gonzalo, si me puedes ayudar en la traducción.
The question is, why
Yeah.
do you prefer to do a paracentesis in the inferior part rather than choosing a temporal area from where you can do the subincisional cortex aspiration?
Juan, ¿por qué prefiere hacer la paracentesis por inferior en vez de sacar el material, la corteza a través de la incisión escleral o por temporal?
Porque nunca me ha causado problemas, es mucho más cómodo y personalmente yo hago todo el hemisferio superior por la paracentesis. Nunca he tenido ningún problema de infección.
It's just because it's more comfortable for him and he's the way he used to do. So that is the reason why he do in that way.
Okay, thank you.
Yeah. Thank you,
Gracias,
Dr.
Juan.
Russo. Yeah, and Dr. Gonzalo for helping out with the interpretation. And we'll have time for discussion at the end. So we move on with the next presentation. And for the next presentation, we have Dr. Neeta Dodwad. We have already heard her in the initial part of the installation ceremony. She is MS ophthalmology, ophthalmologist done from Bangalore, that is the southern part of India. She is currently the medical director at Brahma Netralaya and Gurunit Welfare Foundation in Mumbai, which is in the western part of India. She is also the medical director of the Rotary Club of Mumbai in Kandivali. And in the ISMSICS, she is a very active member and a core team member, and also a joint secretary of the women's wing of the society. And she has presented many scientific papers at different conferences of different levels. So I invite you, Dr. Neeta, for your presentation on CIS, customized incision cataract surgery.
Yeah. Thank you, ma'am. I'll be just sharing my slides now. Are my slides visible now?
Yes. Please continue.
Thank you. Yeah. Good evening and good morning again, everyone. Really, it's my pleasure and honor to be here with amongst all the stalwarts in the ophthalmology. I'm really grateful to Dr. Boramani sir and Dr. Sahu sir for giving me this wonderful opportunity. Today, I'll be speaking on very innovative technique that is Dr. Boramani's customized incision cataract surgery. As we know, the advancement in the cataract surgery has raised the expectation of the patients for the surgical outcome as well as the visual outcome. And the astigmatism plays a very impact on the visual quality of the patient. The prevalence of astigmatism in cataract patient is really high. There are various methods to tackle the astigmatism for the cataract patients. But here I'll be dealing with a customized cataract surgery, customized scleral wound modulation and its impact on the astigmatism. So first I'll start with the case scenario. Here we see a preoperative corneal topography reading. We see here hardly any astigmatism, that is just 0.13 diopter. Patient underwent SICS surgery and the post-operative astigmatism is just 0.17. So hardly there is any change in the astigmatism. Second case, we see a high astigmatism of a 2 diopter at 96. Patient here opted for autofocus lens, that is a multifocal lens. Patient underwent customized incision cataract surgery. We see post-operative astigmatism is just 0.43 diopter. And patient is enjoying a good vision of 6/9 and N6. So with this example, the customized incision has a definitive role for the management of the astigmatism. The scleral incision, as we are aware, are very kind in nature. They secure and heal well They are forgiving incision as compared to the counterpart of the corneal incision. And yes, it gives us a very economical surgery to the surgeon as well as to the patients. As per the present literature, the main advantage of phaco over SICS that it induces less astigmatism. But there is no enough data available, all the literature available to say how the scleral wound modulation gives the desirable result on the astigmatism. The principle of astigmatic funnel is that the incision, which is large and near to the limbus, gives the astigmatism of 1.5 to 1.25. As your configuration of the incision becomes more and more curved, only the central part of your incision takes place for the astigmatism, wherein the peripheral part is away. So the magnitude of your astigmatism will be very less. Now I'll be taking you all through the algorithm which is derived from Dr. Boramani's study, which stages the different size, shape, and location of the incision and its impact on the astigmatism. Here we see a superior straight incision of 7 mm, which induces 1.70 diopter of astigmatism. As further reduction in the size of an incision reduces the magnitude of astigmatism. Next, coming to the superior curved incision. Minimally curved incision gives a 0.58 diopter of astigmatism. As the incision becomes more and more curved, as we see here in the center, the perfect U-shaped incision literally gives no SIA. Coming to the temporal incision, which are weak in neutralizing or stabilizing the astigmatism, they are considered astigmatically neutral. If your incision straight and 7 mm, it induces about 1.8 diopter. As the size comes down, it reduces your magnitude of astigmatism further. Temporal curved incision are again known for its astigmatical neutral incision. This chart is showing the relation between the incision type and its SIA. The superior temporal frown incision induces the least astigmatism as compared to the superior temporal straight and superior-nasal frown incision. The principle here is very important. First, find out the steep meridian and center your incision on the steep meridian. So whatever may be the size or the shape of the incision, the vector forces on both the sides of meridian they act and help in neutralizing the astigmatism. So this is the figure showing the accessible area for the scleral wound modulation. To titrate your incision, one must know his or her SIA. This can be calculated very easily. There are different calculators available on the internet. Put one type of incision in one column and find out your own SIA for different type of scleral incisions. So I'll take you through again few more examples how the scleral wound modulation has given the desired result for the astigmatism neutralization. Here we see the preoperative value of astigmatism is 0.28. Patient underwent a superior U-shaped incision, and we see there is hardly any induction. In fact, there is a reduction in the astigmatism to 0.18. Next is we see astigmatism of a value 0.39. The incision taken on the steep meridian has reduced the astigmatism further to 0.22 diopter. Here we see a little more astigmatism, that is 1.12 at 97. So the superior straight incision has reduced the astigmatism to 1.15 diopter. So this is a less astigmatism or 0.4 diopter at 4. The superior curved incision has reduced the astigmatism further. Here we see a little higher astigmatism at a diopter 3. So the incision configuration has changed. It has become straight. So the reduction in the astigmatism is, and it is the total power after the operation is 0.34 diopter. Here is a very interesting case, very high astigmatism of 3.49 at axis of 118. Large incision, straight incision of 7.5 mm on the steep meridian has further brought down the astigmatism to 0.64. Again, a high astigmatism of a 3 diopter at 97. So superior straight large incision has reduced the astigmatism to just 0.560. Here again, interesting case, patient of a multifocal, he opted for a multifocal. He did not have any astigmatism preoperatively. Curved, very curved incision on the steep meridian has changed the astigmatism to just 0.3 diopter. Here we see preoperatively patient has 1.97 diopter at 170. Patient again opted for multifocal, but this time it is without toric. So the scleral wound modulation has played a trick. The straight superior-nasal incision has brought down the astigmatism to just 0.15 diopter. And the patient is enjoying a good vision of 6/6 and N6 without using a toric, expensive toric IOLs. So these are the few videos showing the reference point making patient in a sitting position 0 and 180 marked with the bubble marker. And in a lying down position, axis is marked with the axis marker and the gauze. In the left side figure, we see 39 meridian is marked. And the straight incision is planned and it is centered on the steep meridian. So this will give a desired result. In the right side video, we see a 70-degree meridian is marked and the incision is planned here according to the magnitude of the astigmatism is frown incision and it is centered on the steep meridian. So this customization of the incision to get the desired result on the astigmatism is published in the prestigious journal, Indian Journal of Ophthalmology. So surgically induced astigmatism, we call it as SIA, this innovatively used to treat the pre-existing astigmatism. So we call it as a surgically corrected astigmatism. Here, the incision is no more small, but in fact, it is customized depending on the magnitude and axis preoperatively of the astigmatism. So it is well known as a customized incision cataract surgery. So few important take-home points. First, give the priority to patient safety and vision. Once the surgeon is well versed with any grade of the management of a nucleus through relatively small incision, he can start planning the customized incision cataract surgery. First, find out what is your own SIA of your different incision. Second thing, preoperatively know the astigmatism magnitude. Magnitude will help to decide the size and the configuration of your incision, and axis will help to decide the site of the incision. Mark the steep incision and center your incision on a steep meridian. And to start with, take the accessible incision sites to start with. So with this customized tunnel engineering, it will definitely help to wipe out or at least minimize the stigma of astigmatism. Thank you.
Thank you, Dr. Neeta, for that elaborate description of customized incision cataract surgery. And as Dr. Carlos initially mentioned, the changing terminology of MSICS. So now we are gradually moving on to customized incision cataract surgery from MSICS. Any quick one or two questions or inputs for Dr. Neeta?
Yeah, the innovator of this customized incision cataract surgery, Dr. Boramani, is there. If any question is really interesting, we have started at our centers. We are calculating our SIA and we are taking the astigmatism, steep meridian and started working on this. It is really giving a good result. So I request all our counterparts to start these techniques and share your results. We can have innovations and research papers on this. Dr. Boramani, over to you.
No, any questions from the audience is
yeah, Dr. Boramani, can I ask a question to you?
Yeah.
First of all, this is a wonderful technique. Obviously, we can modulate our wounds to get the results. Obviously, it is not as easy as you attain. But my question is, how many surgeries you need to put in to get a SIA in a particular location and size? Number one. Number two, in the post-op period, what is your waiting period to give the final surgically induced astigmatism? Is it routinely as we do in phaco, which is 6 weeks, or is it 8 weeks for SICS?
Yeah, to address your first question, every type of incision you should do at least say about 30 cases and then calculate your SIA. So you know at least how your majority of the incisions are behaving, at least in 80% of the cases. Sometimes I also get erratic results. Every time the results are not predictable because the human anatomy is totally, you don't know how the healing will take place. But at least in 80% of the cases, you always get a desirable or very near desirable result. So every type of incision you should try for at least 30 cases. Then you can have your customized incision. You can at least keep doing. So if you don't get a perfect result, at least you are going nearer your goal. Secondly, first and foremost thing, as you said correctly, it is a difficult technique to follow. So those who are novice in SIC surgery, they are not well versed with SIC surgery. They should not attempt at this technique. Only when you are very good at nucleus management through various types of incision, then you can attend this customized incision cataract surgery. And what was your second question?
How long after the surgery?
Yeah, the post-op follow-up. In my cases, generally see scleral incision, they stabilize very fast. I do the final follow-up at 20 days after surgery. So it is only 3 weeks after surgery. Yeah.
Sorry, I have a question.
Yes.
Well, first of all, congrats about the presentation. Was really very, very clear. What is the time you, in this study, for example, when you show us the induced astigmatism, the follow-up is how many months, years? I mean, do you have any works with a long-term follow-up, for example, 5 years or something like that?
Yeah. See, this is question repeatedly being asked to me in various conferences, but I am totally in private practice. So what happens, even if I call the patient after 3 months or 6 months, most of them, they don't turn up. They don't up. So that follow-up is really very difficult for me. But sometimes patient comes to me for some other problem after say 1 year, after 9 months, or maybe for other eye surgery. That time I again do the stimulation study of this previously operated. And in almost 80% of the cases, I found that it remains the same. There is no major change.
Okay, perfect.
Yeah.
Perfect.
I think Dr.
I have a
Carlos
question.
had, yes, yeah.
Yes. Doing this procedure for so many years, you know, I got the idea of trying to find out how much astigmatism I was inducing to the patient with this incision. That's how I started moving my incision further back and further back. But, you know, when it comes to very hard cataracts, the incision has to be bigger in order for you to get it out of there, because harder cataracts are not easy to be break into pieces inside the eye without causing damage to the endothelium or some other places. But
correct.
I normally make a very big incision when I use a hard cataract. But I keep in mind trying to induce as less astigmatism as possible, even though astigmatism is not my problem when I have a hard cataract, because patient does not see anything and they go from see anything to see something a lot better so they are very happy about it. But I didn't understand well. You do a topographic study before surgery. When do you repeat that topography after surgery? How long you wait? 6 weeks?
So that is again
2
20
months?
days. 20 days is my
20
final
days.
follow-up. That time it is done. If you see all the dates on the topographies, they are about 21, 20 days, 2 days apart, because the first was done either 1 or 2 days prior to surgery. So
all right, thank you.
20 days post-operative. Yeah.
Thank you, Dr. Anita, Dr. Puramani sir, and all the panelists for the discussions. Now I'd invite Dr. Rajvinder to carry forward the session and introduce the next speaker.
So our next speaker is Dr. Nilupratna Duri. She will speak on Dr. Sahu's 2mm SICS and ergonomics. So we are moving towards the customization of the incisions. So to reduce the astigmatism, we will be hearing from Dr. Duri from India. Over to you, ma'am.
Is my slide visible? Thank you so much, ma'am.
Yes, yes.
Okay.
Please carry on.
Yes, thank you so much. So at the very outset, a very good morning to all the esteemed guests from Latin America, and also a very good evening to all the honored members of this meeting. So today I would like to speak only on the wound ergonomics of the 2mm MSICS with back incisions. This is a technique that has been done by Dr. Amulya Sahu sir, and I'm extremely grateful to him for teaching me this technique, and also to my mentor, Dr. Harsha sir, for giving me an opportunity to conduct this study in our institute. So I do not have any financial interest in this presentation. And at the very beginning, I would like to tell you that since its first description by Blumenthal et al., the MSICS technique has undergone a lot of modifications that relate either to the size of the incision or either to the way we are delivering the nucleus. So the methods have been changing, and today we would like to test ourselves to see how far we can go to modulate the wound size in order to cause less amount of trauma, and also get the procedure done in a quicker way. So this is a schematic diagram where I'm going to show you that I have made a 2mm frown incision around 1.5mm behind the limbus, and then a back incision of 1.5mm, which are made parallel to each other from either side of the frown incision. And the inner lip of the incision will flare up to 3 to 6mm as per the requirement of the IOL that you want to implant. For a foldable IOL, it is better that you go ahead with at least a 4mm corneal entry, or if you want to place a 5.5mm optic PMMA IOL, non-foldable IOL, it is better if you go ahead with a 5.5mm corneal entry. So here I would only like to bring to your focus about the physics of this procedure. So if you can look at this schematic diagram, you will see that this curved or the convex structure that is represented in the schematic diagram is representing the roof of the tunnel. The surface is this surface represents the floor of the tunnel. The object 1 here is the vectis, and object 2 is the nuclear fragment that will be placed in the center of the tunnel when we are going to pull it out in the direction of the red arrow. So the distance, that is the height of the tunnel at its maximum point when both the objects are inside the tunnel, is represented by the small alphabet D. And the force of tension that will be acting on the membranes, that is the either side of the incision, is represented by these blue arrows on both sides and is represented by the capital letter T. So if herein we are going to take advantage of the characteristic of the two elements here. One is the cornea and another one is the sclera. So MSICS is basically a scleral-based incision. And according to the Hooke's law, if you see that when the stress is within the proportional limit of any elastic membrane, the membrane will always return to its original length when the objects are out of the tunnel. So you can see from the stress and strain curve that this area, that is the elastic area, is represented by the sclera, and this plastic area is the cornea. Therefore, I had told earlier that the flare or the entry into the cornea should be a little larger than that of the scleral incision. So if it is within this elastic limit or within the proportional limit, you need not worry that the wound will gape away. So for this technique, you will require Dr. Sahu's modified instruments, out of which I would like to bring to your notice two most important instruments. One is this Vectis. This is a titanium lightweight, longer Vectis, which has a 2.8 millimeter hanging edge. And another one that I have been using frequently is the flattened tip visco cannula, because I prefer to break my nucleus in the anterior chamber, sandwiching between the Vectis and the cannula. You can also use different phaco-fragmentation techniques for bringing the phaco-fragmentation, which will be discussed in more detail by my next speaker, MS Ravindra sir. So let me take you to the video first. 1 second. Sorry, I'm really sorry. Is the video playing, ma'am?
No,
it's
no,
not playing.
Dr. Dev.
It's not
No.
playing.
It's not playing. Okay, just 1 minute. Yeah, is it playing
Yes,
now?
yeah,
Yes.
yes.
Okay, there's some lag actually. So here you see I have made a frown incision. It's really important that you make a very small frown incision and then place the 1.5 millimeter parallel incisions on either side. You will understand here that in order to reduce the stress on this scleral membrane, you have to make a very thicker scleral roof, but that is not advisable. From the beginning of the presentations here, we have seen that if you make a very thicker entry into the sclera, you are going to end up in a premature entry into the cornea, because the cornea will really give away. So in order to avoid that, what are you going to do is that you are going to make the scleral pockets on either side before you enter the cornea. So this is your entry into, this is your measurements for the tunnel. So when you go into the cornea, you have to understand that this is a smaller incision. So go diagonally into the AC. The keratome goes diagonally into the AC. And when you cut in to the cornea, use a forward movement. Now here I have introduced viscoelastic behind the nucleus so that you can push the posterior capsule behind, because this is not an irrigating Vectis. Then you bisect it in the center, and at one go take out one fragment of the nucleus. For softer nucleus, it is very easy, and then you take out the other one. Here I have even tried to implant a 5.5 mm PMMA IOL, because this incision has not given away. The reason being that the successful execution of this process was pulling out of the nuclear pieces out of the tunnel without tearing the sclera, because the stress was well within the elastic limit of the sclera. So now let us analyze that how we will determine the size of the nucleus and the width of the tunnel. So this is the Pythagoras theorem, wherein from this theory, equation, you will see that the tension force, that is the stress which is acting, that is the force, restoring force which is acting per unit area of the surface of this tunnel, is directly proportional to the change of the length. Length means that is the entire width of the tunnel. So you have to understand that as we go more downwards, that is behind the sclera, the length decreases and the restoring force increases. So in order to avoid this restoring force, you have to make the back incisions so that you can create the pockets and reduce the stress on this membrane. So to reduce the stress, we either have to increase the width, which is why exactly we make the pockets, or increase the thickness of the scleral membrane above, which is not at all advisable in MSICS. So now moving to the height and width of the tunnel. So coming back again to this Hooke's law, you have to understand that the minimum length of the tunnel near the scleral incision and the maximum size of the nuclear piece, that is the Dmax, and the minimum thickness of the scleral membrane should be such that the stress is well below the elastic limit. Because you see from this GIF that is running on top of the screen, if you do not create these scleral pockets, what is going to happen is that your nuclear piece is going to get stuck in the 2 millimeter tunnel, and you will think that you have made a 2 millimeter incision, but actually you have expanded it because the elasticity of the scleral membrane has gone well above its proportional its limit of expansibility. That is why it is not advisable that you pull out the nucleus thinking that you are doing a 2 millimeter, but actually you have caused more damage to the wound. So this causes a purse string effect. So secondly, while pulling out the vectis, you have to understand that you cannot pull out the vectis indefinitely in a horizontal manner. Why? Because there are two forces that are acting on this tunnel. One is the horizontal force, that is the T cos alpha, and the other one is the vertical force, that is T sine alpha. Because here the angle alpha is given only by the that is the angle that is created between the roof and the scleral floor. So for any horizontal pull, the friction N between the vectis and the scleral membrane will include both the weight of the vectis as well as the weight of the nucleus. So the frictional force will be F is equal to mu N. Hence, the material of the vectis should be lighter. Therefore, I had explained that you need to have that over the 2.8 millimeter overhanging edge lightweight titanium instrument, and the nuclear piece should be smaller. Therefore, you need to bisect the nucleus before you take it out. So the acceleration with which the nuclear piece can move sticking to the vectis, which is known as the threshold limit of this vectis and the nuclear fragment, should be well within this limits. So for a force that is less than this, what will happen? That the nuclear piece will not be able to overcome the friction with the scleral membrane above. And for forces above this, the nuclear piece will slip the vectis. That is why when you pull it out, it will slip. So in order to avoid that, what you need to do is that you make another angulation. That is, you make an inclination of your vectis at an angle of theta. So what will happen? The combined upward push and the horizontal pull will now be inclined at an angle theta and will reduce the friction between the vectis and the scleral surface downward, because you have now tried to negate this angle alpha by just making the vectis a little upwards. So you see here, if you are pulling this nuclear fragment horizontally, what is happening is that you have actually expanded the tunnel. You are not supposed to do this. You have to slide it a little up to create an angle theta. So if the push upward F sine alpha overbalances the entire weight of the vectis and the nuclear fragment, the scleral membrane will be stretched more, and which will stress it closer to its elastic limit. So in order to overcome the friction force between the scleral tunnel above, you apply OVD constantly or continuously while pulling out the nuclear fragment. And to create the angle theta when you are pulling the vectis upwards, your acceleration will be dampened by the soft scleral surface below, or the cushioning effect of the ocular coats, especially the choroid and the sclera together. So therefore, you need to understand that as a straight incision, you cannot have a trapezoid entry into the, or trapezoid geometry in this case. You will have to have a creation of scleral pockets, and you will get good results. The clarity of the cornea will be good, and even the wound healing will be better. Because if you do a trapezoidal one, thinking that it is a straighter incision, you will end up pulling the superior iris, you will injure your cornea, and your post-operative results will not be good. We do believe that it is not comparable to phaco, but the surgical results can be comparable to it if you can master this technique. So we have even tried to look at the OCT images post-healing, even up to 6 months after the surgery, and the wound healing is absolutely okay. There are questions that whether this incision will cause more trauma because we have created the side pockets? The answer is no, because the side pockets are created by creating the back incisions. The side pockets are not created from the edges of the wound. Therefore, the rigidity or the integrity of the wound is maintained in this case. So we compared it with phacoemulsification as well as with 6 millimeter. But herein, I'm only going to discuss about the 6 millimeter incision comparing to 2 millimeter, which we have already published. That the astigmatism that you induce in these cases is around 0.75 if you are implanting a PMMA IOL. But if it is a foldable one, it is around 0.5 millimeter SIA. But this will negate to zero if you place it in the steeper axis. I am a surgeon who operates from the superior axis. So for me, sometimes if it is a 90-degree, it does create some problem in terms of astigmatism. The continuous irrigation of the OVD while pulling out the nucleus will give you excellent results in terms of the CV and the hexagonality index, protecting your endothelium post-surgery. So my acknowledgements to my brother-in-law, Dr. Joyprakash Das, for helping me out with this presentation, especially the physics of the procedure, and my students for helping me with the making of this presentation. Thank you so much for your patient hearing.
Dr. Deori, wonderful presentation. So you have added physics to the ophthalmology in making us understand the ergonomics of the 2 mm incision. So I just want to know that after how many surgeries one should try to do 2 mm SICS?
If you are already practicing surgeon for MSICS, it is better you go ahead with at least 10 surgeries where you are creating a 4 millimeter incision, then going to 3 millimeter incision, and then go to a 2 millimeter incision with back cuts. You need to understand that while doing the surgery, since you are creating a uniform plane on either side of the 2 millimeter incision, ambidextrous, like you are using both hands, ambidexterity is an advantage for you. So I feel that if you are prolific with SICS, then it will really come easy to you after 10 surgeries.
Over to Dr. Sahu, sir. What thing led you to discover 2 mm SICS?
See, when I formed this chapter, the whole thing was that SICS was a messy surgery, you know. So phaco gave a clean surgery and everybody wanted to go for phaco. So, but SICS was, preventing the blindness in a big way in India. So I said, these people are not getting any kind of importance which they deserve, you know. So the platform, I thought, in this platform only they can get their respect. And every conference, the machine was paraded as I have this machine, that machine. So everybody was marketing the machine, and the people who are rural setup, they were doing surgery, they were feeling inferior. They were, in fact, were not telling that I am doing SICS. So I said, it is unfortunate. It is not good. So the platform now, everybody wants to be on our platform. And SICS has got the thing. And that time, the incision was big. So I said, if I can reduce the incision to a size and give similar results, then everybody has to wake up and say that, well, why not? So in case our astigmatism is much less and we are giving a hemetropic situation, and next day the patients are very good, and corneal wound is the sclera wound is a stable wound, and we are covering with tannins and conjunctiva, and gram-positive negative infection is minimum. People can go away, come after months, and no problem, you don't have to worry. But in the corneal incision, if you see, they come back with so many problems afterwards. The irritation continues for a long time, and so many other things are happening. So the main incentive was to whether I can go, to modify the instrument, and went on modifying. And then I found that the 3 millimeter I demonstrated in 2005. And then 2018, I think All India Institute, I demonstrated 2 millimeter. So I think 2 millimeter here to stay, and it compete with the phaco. I think all the senior surgeons must try this method. And only thing they have to have my instrument, or otherwise they will have to modify their instrument, taking cue from my instruments, because they have been modified for a very long period of time of trial and error. So that will benefit. Without that instrument, 2 mm should not be tried, because then they will damage so many things. Because our vectis which is available is not engaging the fragmented nucleus. So I am dividing the nucleus now in the bag. So I think that's the future, I think all senior surgeons must try their hands for 2 mm. And you have learned, and so I'm
Yes,
going
sir.
to your place.
Yes, sir.
So I think
Yeah, we are
next
looking
time,
forward to you, sir.
yeah,
Boramani, sir, and you, sir.
I want you to present 2 mm your experience, okay? Next
Yes,
time.
sir. Yes, sir. Any questions from the seniors? Dr. Carlos Gomez, he wants to
Yes,
know.
Carlos is one who should try now. He is a
Yes, sir.
master. Yours,
I
I saw your
like I
surgery,
said,
and very neat and
like I
clean.
s- yes, like I said in my presentation, if I stop learning, I will lose passion for what I do. So I'm learning everything that I'm seeing here right now. How big do you do the incision when you have a very hard cataract? Because the cataract you showed, we get a lot of those, but for the hard
Nay,
cataracts are very difficult
nay,
to get out of the eye.
you don't go for very hard cataracts in 2 mm. Don't do that, because it's
Oh
not
no, I
very.
know for sure.
Nay, it is not.
I'm sure.
It is not I think up to grade 4 you can go, but beyond that, don't.
Very interesting case.
Yeah.
Yeah,
But
I
you
want to ask something. Sorry. For dissect the nucleus in the anterior chamber, what technique do you prefer? I mean, just put the vectis in the back and some instrument upside,
see, you
or
keep the vectis below the nucleus and on the iris diaphragm, and then this visco cannula. You see, it is a round thing. When I was introducing that thing, in the if you are introducing to the side port, that is a flat incision, and a round thing going in a flat, you will have a descendant separation. So what I do, that visco cannula, I just press it and make it flat.
Yeah.
So it and go on injecting visco, and then go on pressing the nucleus above the vectis, and
Okay,
then
perfect.
it will smoothly divide.
And what do you think about the loop, the lens loop? Something like the MI loop of size, or something like that.
Yeah. So can I come in here?
Yeah.
Yeah, I have kept this video in my presentation for a very long time, for the very reason to show you that if it is a softer nucleus in a grade 2 or softer nucleus, it is easier to crack in the anterior chamber. But if it is a little harder, 2+ or 3+ nucleus, it is better if you go ahead with the in the back fragmentation. Especially so if you need to have those instruments where you can use the MI loop, maybe the snare, or maybe the this chopper and the pre-chopper together in order to crack the nucleus before you prolapse it into the anterior chamber. But in this case, first you need to prolapse it into the anterior chamber. Then once you have prolapsed, put in a little viscoelastic behind so that the posterior capsule is pushed behind and the nucleus is well above. Some amount of visco should also go between the endothelium, that is the cornea, and the nucleus. Once your left hand, if you are a right hand surgeon, your left hand introduces this vectis straight into the underneath the nucleus, then with the flat-tipped visco cannula, you keep on injecting the visco once you are inside, that is on top of the nucleus. Then as you keep on cracking it, just keep on injecting the visco continuously so that it cracks, and then you can take out the nucleus, slide out the nucleus very easily. That is why I have specifically told that the threshold force, that is the threshold friction, this is the friction that you are creating between the corneal endothelium and the nucleus. It should not be there. Your OVD should be injected at all points of time. And I think Ravinder sir will be the best person to tell you about the phaco section or the phaco fragmentation. in his next presentation, where he will show probably different types of fragmentation. So continuous OVD irrigation is a must in order to avoid those complications, because rubbing of the nuclear fragment, especially when it is broken down on the endothelium, will give you bad results. Your CV goes down for this on the specular, and your post-operative central corneal edema is too much. I mean, you really need to take care of that.
Over to you, Dr. Puri.
Yeah. Thank you, Dr. Niluparna and Dr. Sahu sir, for elaborating very well on the 2mm SICS. And so we come to the last presentation of the day. I have the pleasure of introducing respected Dr. M.S. Ravindra sir, who is a very revered senior and experienced surgeon of India. And he is not only a great surgeon, but he's also a very dedicated and excellent teacher, because we all keep learning from the videos that he keeps sharing on different media, and they are also brilliant. So he's the medical director of Kartika Netralaya, Bangalore, which is again in South India. And he has done fellowship in VR as well as cornea, which adds to his experience. And he has been the prestigious recipient of numerous awards, including a Lifetime Achievement Award. And it's always a pleasure to listen to sir and see his videos and learn from all of them. Over to you, sir.
Good morning. Is that slide visible?
Yes, sir.
Yeah, is that playing? Can you confirm that?
No,
It's
not
not.
yet. Yeah.
Yes, now yes.
Fine. Good morning and good evening. It's my pleasure and my honor to have been introduced to this inauguration of Latin American MSICS program. And I congratulate and I wish all the best. So what I'm going to talk now is a technique. There are many MSICS techniques. The one which I've been following, as Dr. Carlos mentioned, I'm very keen to learn. I've picked up a lot of points from his surgeries. And whatever surgery you do, the cornea should look very clear on day one, as Dr. mentioned just now. The cornea should be absolutely clear on day one. And this is a mature cataract. This is post-op one. I always prefer to do a temporal incision because the patients at that age, most of them have ATR, and this will reduce the ATR, as Dr. Boramani's study has shown, temporal incisions. I make a direct incision with the 2.8 keratome, starting from about 0.5 to 1 millimeter on the conjunctival side beyond the limbus. That involves the anterior sclera. And soon after that, I'm going to inject viscoelastic into the eye, and I'm going to do a rhexis. This is a case which we diagnosed to have tumorousness of the lens. There was a lot of lens shaking, and patient gave the history of severe trauma. And you can see how much the lens, entire cataract moves during the rhexis. I intentionally did a larger rhexis in this patient. I've entered the AC through a puncture in the floor of the tunnel. I did not enter through the tunnel. So that keeps the viscoelastic inside the antechamber very well without shaking. That's the hydrodissection. And normally I don't expect this pole to vault into the antechamber. And I would like the other pole to vault, the opposite side. But here, for some reason, maybe because the bag was loose, it broke. It prolapsed from the temporal side. You can see the nucleus is in the antechamber, and there is a great danger of damaging the endothelium. So this is a hard nucleus. My entry is 5.2 millimeters. This, I think we missed it explaining that. And it's not going to come out through a 5.2 millimeter unless it damages. Dr. Niluparna said, if you bring a large nucleus through a smaller tunnel, you're going to damage the structure of the tunnel on the cornea as well as the stretchable sclera. So I'm routinely going to do a bisection. Normally, I do a bisection with a 25 gauge cannula, but here being a hard nucleus, I can't do it. This nucleus is mounted on this needle cystotome is bent not at 90 but at 45 degrees, and that enables me to perforate at the limbus when I enter inside. So it's a anterior chamber is a sealed cavity when I'm actually doing the rexis, but now I've opened it up to 5.2 millimeters. This cannula is continuously injecting dispersive viscoelastic in front of the nucleus. As the nucleus moves, you can see I'm injecting continuously viscoelastic. Now, as you can see, this cannula is in front of the nucleus, and it's again continuously injecting. Now, normally at this stage, in such a case, I would remove the capsular bag and put a scleral fixation lens or some such adoptions, modification. But here I thought, why not leave the capsular bag? Though the support of zonules is very weak, 360 degrees, why not leave it back and then put a lens? If I put a lens in the capsular bag, it's going to fall down in a matter of time. If I put a three-piece lens, there is still a danger. But then I decided to modify it. The first time, I'm presenting, I have not seen this in literature. The capsular bag is intact in the eye, and then I put an iris claw lens. And normally, iris claw lens is fixated in front of the iris, and that is known to damage the endothelium over a period of time. Now I'm going to take this iris claw lens behind the iris in the sulcus, as you can see there, and enclavate there. So it's a posterior chamber lens in the sulcus. And what I've saved here is damage to the compromising the posterior capsule. I've saved the vitreous cavity, and I don't have to fix the lens by scleral fixation. And it's a very quick surgery done under topical anesthesia. It doesn't take more time than a normal cataract surgery. And now the surgery is over. I'm going to inject a little bit of moxifloxacin and remove the entire viscoelastic from the eye. That's very important to prevent secondary glaucoma. I don't need to bandage the eye. The patient doesn't even know that I've done a major surgery on the eye, and he is well rehabilitated right from the day of surgery. I have a couple of more. You please tell me when I need to stop. Till then, I can go on for another couple of minutes. This is a case, one-eyed patient. He had good vision, and he's got a huge corneal scar, adherent leukoma, right in the paracentral zone. And this is because of smallpox. The other eye had damaged completely. He was tricycle in the other eye. And patient did not wanted a cornea grafting surgery because he was scared of surgery. He waited till this stage, till he lost all the vision. So I have separated the anterior and I've stained the anterior capsule. And I could do a good rexis even in this patient in spite of this thing. I've released the contents of the capsular bag. It's a ballooned out the lens capsule. Again, I had to put one iris claw lens to dilate the pupil on this side, rotated the nucleus, lifted it up, brought it to the anterior chamber, and then again bisected it. Continuous infusion of viscoelastic, and without damaging the endothelium, we could remove the entire nucleus. And patient has been very happy with the regain of the vision, which was better than what he had long time ago because of the refractive correction. He didn't wanted us to do anything for the. He's a very. He argued that he had good vision and he had a corneal opacity before the cataract came. Please remove the cataract and let the opacity be there. That's his argument. And this is another thing I do. I don't. I many times I take the lens cartridge, put a lens inside, and instead of hooking it onto an injector, I push it with a. This is how it looked like immediate post-op. There's another very interesting case. It looks, a different kind of cataract with a lot of shadows and a lot of corneal astigmatism. And you can see the posterior capsular cataract, which is got onion rings and all those things. This is excellent technique because the pressure inside the eye is never more than atmospheric pressure. I removed the cataract. See, posterior capsule is intact in spite of a posterior, dangerously looking posterior subcapsular cataract. I put a toric lens. I'll go a little fast. Aligned it to the axis. Then I see this right now when I'm increasing the pressure at the end of surgery, and there is a give way of the posterior capsule. So that means the posterior capsule was inherently weak in this patient. Because I did not do a phaco and I did an MSICS, I could keep the integrity of the posterior capsule because it's a low flow, low pressure technique. The amount of fluid that's needed to do surgery is only about 20 to 30 ml. And the intraocular pressure is never more than 20 or maybe at the most 25. But when I increased the pressure a little more at the end of surgery, I had a tear in the posterior capsule. So the lens is well aligned. I just left it out. And there's another case. I just demonstrate how to use a loop inside there. This is indigenously made loop. It doesn't cost anything actually. And and you break the continuously inject viscoelastic, and then you break the nucleus into two pieces. It's a very hard cataract, and you can easily, just like you cut butter, you can cut the dense nucleus, and through an incision which is about 6 millimeter, you can see the hemisize. This cataract may be about 4 millimeter hemisize in the half portion, but it also has got a thickness which you need to consider. So again, inject viscoelastic continuously, hold the nucleus with a mini vectis, support it and take it out. This is another very interesting case. We argued whether it's a posterior capsular or a posterior subcapsular cataract. I do a rhexis, and then I do a hydrodissection in all these patients, segmental hydrodissection, because I always think that all the problems we have in a posterior subcapsular cataract is because we don't do a hydrodissection. So I do a complete good capsular dissecting hydrodissection, sometimes mechanically separating it. And then you can see there's a little bit of hydro delineation also, which I don't like. I just wanted to do hydrodissection. Then you can see that's the as you remove the nucleus, is a young patient, so it comes out by viscoexpression. Very carefully. And as you remove the cortex, you should be very careful. Here is the time when posterior capsule tears or breaks, but now because of the low pressure, it's an open eye. It's not a closed eye like when I do a phacoemulsification, I increase the pressure. So the posterior capsule remains intact throughout. So then you can put a lens of your choice into the capsular bag. So the advantage of the ISMSICS is not only it improves your skills, it keeps your skills very intact, and it allows you to do surgery on very complicated cases where a neat phacoemulsification is a little difficult, and also in routine cases, like especially in pseudoexfoliations and in posterior capsular cataract, because the pressure and the fluidics that is involved is very, very low, very slow and very low, and the risk of posterior capsular tear is not there. Thank you.
Thank you, MSR sir, for those excellent videos as always. And transconjunctival incision is something which I have learned from your videos, and you might remember that I've asked you questions also on WhatsApp. So any quick questions or comments for MSR sir?
Yeah, a little more elaboration on the use of cartridge. I think you are using cartridge only as a guide without plunger. Am I correct?
Yes, I use a cartridge, and I have got special pistons. They are calibrated to the opening of the cartridge, and you just push it through the hole. And the lens, the advantage is that there is no sticking of the lens to the capsule accidentally. Sometimes it gets stuck, and that's totally not there. And you can the most important thing is you can push the plunger as much as you want, and then bring out the plunger, the piston remains inside. After the plunger is removed, you can remove the piston.
Okay.
There are two different instruments instead of one in the
Ravindra, you do this 3 planar incision, or you do, what is your?
It has to be a 3 planar incision if you want. My tunnel has got a straight towards the corneal side. Straight, it's not curved like most of the incisions. And on the scleral side, it's straight. Both are should be rectangular tunnel. For that, it has to be the knife. It's a very good question. The knife has to be in the mid thickness of the cornea sclera. If it is deep, it will create actually a frown incision on the corneal side, which is not recommended. So it should be exactly in the half thickness of the tissue. And it's a 3 planar. You have to go vertically down and straight, again down and straight.
Another thing is that you are injecting visco with a 26 gauge cannula.
25 gauge cannula.
25 cannula. Because it's so much resistant. I have tried it in the future, in the past. But I found it is maybe it in your hand looks okay. But for a beginner to do this, there is a lot of risk involved, I think.
You need to use a syringe which is lower lock. Otherwise, sometimes if there is a little bit of viscoelastic on the tip of the on the nozzle of the syringe, sometimes it comes off. This has happened to me 10, 15 years ago. Then from that time, I use for visco only lower lock syringe, so it gets locked. So needle doesn't get separated from the syringe. Number one. Number two, you hold it with your thumb, like the way I'm holding it like that, and I'm injecting in that position, so you'll get much more strength from your thumb side. So the viscoelastic easily goes through a 25 gauge cannula. And when I use the cystitome, it's actually a 26 gauge regular needle. So even through that, viscoelastic goes. But only the pressure that you'll get used to that pressure that you're going to inject. But you should not sort of remove the needle from the syringe.
Okay. Any questions now? I think
yes.
Yeah, I said 2 spellbound for questions.
No questions in the chat box.
So I think as we come, it's been almost 2 hours, and I think none of us realized. As we come to the close of the session, any quick comments from anybody on the panel? Dr. Carlos, Dr. Gonzalo, any quick departing comments you would like to give?
No, for us, it's just an honor to be part of this, and thank you for the space, and it was a great webinar for us. So thank you. That is all I want to say. Thank you to let us to be part of this. Just that.
Thank you so much.
So thank you, Gonzalez, and everybody from Latin America. And we want to see you in a big number in Delhi. And we want all your flags, which should be hoisted there. And by the way, Purvi is our journal, global journal editor. So send your articles to her, and we can have a Latin American issue. Purvi, am I right?
Yes, sir, definitely.
After
Yes,
the
sir.
Russian issue.
That sounds like a great idea. Thank you very much for everything. I really enjoy being here and sharing with you and learning from you everything that I can. So really appreciate it. It's been a great day. Thank you.
Thank you so much. Good night. Have a good day
Thank
to
you.
all of you.
Ma'am, we can have a quick photograph.
Dr. Boramani, sir, any quick vote of thanks or comments before we part?
Dr. Boramani, to give a vote of thanks.
We thank everyone, the whole Latin American chapter of ISMSICS and all our colleagues from ISMSICS for active participation. I sincerely thank Dr. Aarti and Dr. Nita for installation ceremony. Also thank Dr. Purvi and Dr. Rajvinder for smoothly conducting the CPD. And thank you all the chairpersons, Dr. Noe Rivero, Dr. Gonzalo, Dr. BNR Subudiri. And I thank the speakers also. All had given excellent deliberations. Dr. Carlos, Dr. John, Dr. Nita, Dr. Nirutparna, and Dr. MS Ravindra. So I thank the discussants also, Dr. Barun Naik and Dr. Ashok Nanda. And last and not the least, I thank Entodd also for being our partner in this webinar. Thank you.
Thank you, everybody. Good night in India and good day in Latin America. Thank you.
Yeah. Thank you.
So let us keep meeting frequently now.
Yes.
Thank you. Okay. Good night.
Thank you.